Now, I guess when we start, can I just share my screen for the presentation?
Absolutely.
Perfect.
Yeah, typically, you can talk for as ever long you want. Basically, we typically have you share your screen, and then at the end we'll have a kind of open discussion. We can take questions from the audience and everything.
Great.
How's it going over there?
Not too bad. I mean, as good as it can be with this whole COVID situation going on.
Yeah.
Yeah. How about you guys?
Well, New York was fortunate. It was pretty early on that we got kind of hit with this. There's some upticks in a few neighborhoods, but for the most part, the hospital has been functioning, almost at baseline from pre-COVID time, which is nice. There's still a COVID unit and we still have cases. How about you, Nitesh? Nitesh is out at Rutgers.
We've actually sort of seen a slight uptick. It's nothing too outrageous, just a handful, but it's sort of similar to what you guys have in New York.
Yeah. But the numbers up in Toronto are stable, or?
It was ticking up for a while for the past week or so. And, I think everybody's kind of worried about the second wave coming.
Yeah.
So, back in the spring, we were essentially shut down the radiation department for all routine treatments for quite some time. And that created a huge backlog. So we're obviously hoping that's not going to be the case here.
Yeah. Have you seen a lot of advanced pathology? I know there are reports of things like that. People that just didn't come in for 3 or 4 months.
So not so much, I guess, in CNS. I try to keep pretty close tabs on those patients. And the other site I happen to treat is prostate or GU, and fortunately those guys in most cases can afford to wait a couple months, and it hasn't been a huge issue.
Yeah, excellent. We got about 2 minutes. I'm just going to mute you guys for a second, and then we'll get started at 4 promptly.
Your attention, please. Would Catherine McPherson please return to 10 Mike Wade, first floor of room 202?
Eric, if you want to upload your slides, we can just at least have the front cover of your slides up.
Sure. Do I just share my screen?
Yeah, you can share content right from Zoom, the bottom window.
Sure. Do you guys see that?
Perfect.
Okay?
Yep.
Yeah, excellent.
Perfect.
All right, well, it's about 4 o'clock, so we'll get started. Welcome back.
We are
everyone.
live.
Excellent. So welcome back, everyone. This is another edition of Tumor Talk. This is a collaborative effort between Lenox Hill Hospital and the Journal of Neuro-Oncology, where we present and have authors present their recently published research in the journal on brain and spinal cord tumors. And today, we're pleased to have with us Eric Tseng, coming from University of Toronto and SunnyBrook Health Sciences Centre. And he's going to be talking about their recent publication, talking about glioma consensus contouring and recommendations from an international consortium research group. So thanks so much, Eric, for coming along. I think Jason's signing in now. Remember, we are live on Instagram Live and we're live on YouTube Live, and this will actually be put online later for any of those who miss any piece. So.
Great. Thank you very much, Randy.
Hi, it's Jason. Can you hear me?
Hi, Jason.
Hey, Jason, how you doing?
I'm well. Hope everyone is doing fine too. Thanks for joining, Eric.
Great. Thank you very much for inviting me.
Our pleasure.
So I guess I'll go ahead and get started. So my name is Eric Tseng, as Randy mentioned. I'm a CNS radiation oncologist from SunnyBrook Health Sciences Centre in Toronto. And it's really a pleasure this afternoon to have the opportunity to discuss our recent publication in JNO, particularly on the glioma consensus contouring recommendations in the context of the MR-Linac International Research Consortium. And as mentioned before, I want to take this opportunity to thank both Jason and Randy for their kind invitation to discuss this in a very interesting format. So those are just a couple of points of disclosure. It's really nothing related directly to this work. And just a little bit of background, as most of you know, MRI really has been used for radiation definition of brain tumors and organs at risk, such as the optic structures, since the inception of radiotherapy for brain neoplasms. And this is really quite different from other anatomical sites that we treat as radiation oncologists, many of which extracranially are still primarily CT based. And we know that the current standard of care, or the paradigm for high and low grade gliomas, is really maximal safe resection followed by radiation with or without concurrent and adjuvant chemotherapy. In terms of radiation definitions of the tumor volume, there's been a few pre-existing guidelines that's been published. And on the next slide, I'll just briefly summarize that just to put things into a little bit of context. Just in terms of sort of fundamentals of radiation definition, what we call the GTV, or the gross tumor volume, essentially is the enhancing portion, or the T1 plus gadolinium portion of the tumor. Now, depending on the collaborative group, NRG, for example, for the larger volume, they also include some of the T2 hyperintense tumor. The CTV, or the clinical target volume, is typically an expansion beyond that of the GTV to, in principle, encompass microscopic extension of disease. And this principle is used in all anatomical sites in radiation oncology, not limited to the brain. Beyond that, there's the PTV, what we call the planning target volume. And that's essentially a margin that we add to account for the uncertainties in setup, in patient motion, and so forth. So what you see in this table here, the first publication that came out about 5 years ago was from the Korean Radiation Oncology Group, where they essentially had 15 radiation oncologists across different Korean institutions contour 9 cases of GBM to look at sort of variations between the observers. Unfortunately, in this particular publication, even though they did some statistical analysis, there were no specific recommendations in terms of CTV modifications relative to the adjacent anatomy. And then the second publication that came out was a statement from the Estro-ACROP group in the Green Journal a few years ago, where they did lay out some recommendations in terms of the CTV expansion. But unfortunately, this publication did not really look at any quantitative analysis. So there was no contouring done in this particular statement publication. The more interesting one was the more recent one from Cruiser and other co-authors from the NRG group, where they did look at 4 GBM cases contoured by a panel of brain tumor experts. And in this particular publication, they did lay out some recommendations in terms of how CTV should be expanded relative to the adjacent anatomy. One interesting point to make here is that the NRG, or the RTOG definition of target volumes, are essentially broken into 2 phases. The first phase given to 46 gray, which is what you see the 4600 volume here represents. And then the second phase adds another 14 gray on top of that to make the 60 gray. The first phase volume includes both the enhancing disease as well as the T2 hyperintense disease, plus another 2 centimeter margin beyond that. So it's quite a large volume. And then the second phase, what often referred to as the boost phase, essentially shrinks down on that for the last 14 gray. Now, the European the Estro approach, as well as across most institutions in Canada, we actually adhere to the European approach, which is a single phase approach, where the entire volume is treated to 60 gray. But it is a smaller volume than what would be defined by the first phase of NRG. So that serves as a little bit of motivation for defining sort of our target volume in our particular work. And I'll go into that in just a few slides. Now, just a couple of things in terms of the MR guidance aspect of radiation treatment, which is another big part of the motivation for this work. Now, currently, image guidance in external beam radiotherapy is primarily based on cone beam CTs. So the images essentially is taken prior to beam on for radiation treatment, and that is to verify the position of the patient and to ensure reproducibility every day. Now, there is some secondary imaging dose obviously associated with CT. As you know, intracranially, the soft tissue contrast is extremely poor for CT, particularly in a cone beam CT, and it does require bony anatomy and or fiducial markers. There's also obviously other sort of image guidance systems, which I won't go into too much today, but systems such as a CyberKnife, which provides near real-time imaging, but again, it relies on bony anatomy and or fiducial markers. Now, with the emergence of MR guidance in recent systems, really this offers several distinct advantages. One is superior soft tissue contrast. There's the ability to image while the beam is on, which provides the ability to actually monitor the patient in real time, and not just limited to the brain, but this provides the ability to monitor for physiologic motion, for example, which if you're treating lung tumors, you can monitor for respiratory motion. There's no imaging related radiation, and as mentioned before, there's direct monitoring of anatomical changes, whether that be deformations or tumor response, organ filling, physiologic motion, etc. And sort of the holy grail, at least the way that we've looked at this for MR guidance, is the possibility to incorporate down the road functional MR sequences that can tell us more about the metabolic activity and potentially provide imaging biomarkers to predict response at an early time point, and therefore select patients or modify the treatment pathway. So there are several systems on the market right now. V-Ray Meridian is one of them. Elekta Unity is the one that's currently available at SunnyBrook. There is another Alberta system which has been commercialized recently. Australians are also designing their own MR-Linac. As far as I'm aware, right now this is still in the preclinical phase. So in terms of the MR-Linac, specifically the Elekta Unity, for the development of the machine, the consortium was formed about seven years ago by 7 founding institutions, which you can see on the right-hand side. SunnyBrook was part of that. And really this was to develop both from a technological aspect and hand in hand with evidence-based sort of clinical indications that the machine can be applied to. And as you can see in the diagram here, there's a number of tumor sites that were identified up front that could benefit from MR imaging, the brain being one of them. And SunnyBrook really has led the brain sort of consortium efforts in this respect in the last 7 years. So with that as sort of the background context, this really motivated the development of an MR-only workflow as well. Right now, for all radiation planning, we require the usage of CT up front, which provides the electron density information. That's how we calculate the dose. But if we're using an MR guidance machine, then there's a potential to streamline the entire workflow and eliminate CT from the entire workflow. So as one of the primary motivations for this multi-institutional study was one to look at the inter-observer variabilities when we're defining targets and organs at risk intracranially in the context of the consortium, also to serve as a baseline for future collaborative studies. And also we wanted to look at how things might differ between the two workflows when we're fusing the CT to the MRI as per our usual workflow, or if we're working in an MR-only environment. So for this particular study, we looked at 10 cases, the first 4 of which were in fact done on the cloud with each participants at their individual institutions. The latter 6, we brought them over to SunnyBrook, and we did an on-site workshop, after which we completed all the delineations for the 6 cases. The 10 cases consisted of 5 GBMs and 5 lower grade gliomas, grade 2 and grade 3s, with intentionally chosen varying sort of tumor locations and proximities to white matter pathways. So 6 oncologists from 5 institutions. We delineated GTV, CTV, OARs, and did the usual expansions as per recent trials, so 1.5 centimeter for GBM and 1.0 for grade 2 and 3 gliomas. As mentioned before, we tested 2 separate workflows independently, so MRI only without any CT information, and subsequently provided them with a few CT and then asked them to re-delineate all the structures on that. Staple analysis, which is an expectations or a maximization probability algorithm for estimating the underlying true contour, was used to essentially analyze all the contours to obtain an average, if you will, and eliminate the outliers. Inter-observer variability was then calculated both with other similarity metrics such as DICE and kappa statistics using a mixed model. So here's just an overview of the 10 cases that we've chosen, 5 of which, as I mentioned, was GBM, and the other 5 being grade 2 or 3 gliomas. So I think just to highlight up front that the concordance in the GTV and CTV contours in the agreement was essentially very, very high, ranged from 0.86 to 0.88 across all the measures. We also ran a number of other similarity metrics, which I didn't highlight here, but things like Jacquard and Hounsdorf, for example. At the bottom hand panel are sort of 4 just illustrative cases where the white contours are the staple contour. So that's essentially the consensus contour based on analysis of all of the individual contours, and the different shades of red being the individual contours. As you can see, the GTV concordance or agreement was very, very high. In terms of the OARs, all the concordance or agreement were very high, with the exception of optic chiasm, which is slightly lower, as you can see here, 0.58 to about 0.6 for the mean kappa, and cochlea being a touch lower even. However, this subsequently improved with the workshop, which I'll show a little bit later. As you can see here, the statistical p-value difference here highlights the fact that with the addition of CT information, cochlear contouring improved dramatically. And that's primarily because for typical radiation simulation sequences, we do not use a dedicated T2 weighted sequence, which is really needed when you have thin cuts through the temporal bone in order to delineate the cochlea, or you have a high resolution CT through the temporal bone, which were not available with an MR only approach. Once you fuse the CT, then the individual participants were able to identify that structure much better. So this illustrates some of the variability in terms of contouring the optic chiasm. It's really the extension in the anterior and posterior limbs in this particular case, even though we've sort of very strictly defined it as 5 millimeter beyond that of the intersection. There is still variability here as illustrated here. What I had mentioned was that after the on-site workshop, and this highlights an important sort of educational component of this, is that despite these being fairly experienced radiation oncologists who treat really gliomas on a regular basis, with workshop where we invited neuroradiologists to go through every single structure anatomically, this did statistically improve, at least in the case of the cochlea, in terms of contouring agreement. This highlights the 10 cases, and I apologize if the images are a little bit small to see, but I just want to highlight that these were intentionally chosen sort of along in varying locations intracranially and along with differing proximity to white matter tract pathways. So for example, here in case 8, you have tumor extending into the thalamus, whereas in case 6, we chose one that was extending into the ependema with intraventricular extension. Other ones, such as case 9, were intentionally chosen with extension or at least proximity to pathways such as the corpus callosum. And that just sort of illustrates some of the variations that we've seen in the GTV contouring. And based on, after all the contours were collated and then analyzed using the stable approach, we then essentially, for each individual case, we met virtually with all the individual institutions that were participating to go through the stable contours to ensure that there was agreement in how the contours came out and whether the contours made sense in terms of the anatomical boundaries. And with that in mind, we came up with 6 recommendations in terms of CTV contouring relative to the adjacent anatomy. And some of these are pretty self-explanatory, straightforward. In the absence of contiguous white matter tracts, the CTV should be limited without additional margin by the various falx, tentorium, intertable skull, as it's extremely rare to see gliomas extend beyond those, which is different from metastatic disease, for example. Second, the brainstem is an anatomical barrier when it's not situated along a contiguous white matter pathway. For example, in the case of the temporal lobe lesion, as you can see on the left-hand side, whereas obviously if it's situated right along the thalamus or internal capsule, that would be a potential pathway. The CTV should be limited without additional margin by the optic nerves and chiasm. Again, for cases such as this temporal case where there's no direct pathway to spread into the optic tracts, whereas if it's right along the optic radiation, then you would be including the distal portion of the posterior limbs. The CTV does not need to be excluded from the ventricles, particularly in the case where we are suspecting or we are confirming ependymal involvement or intraventricular extension, such as in this pineal case, and in this case on the right-hand side. And then in terms of, and this is an important point that we've noticed many radiation oncologists, unfortunately, missing this component of the extension when it's right adjacent to corpus callosum or other pathways such as the anterior or the posterior commissure, where we would intentionally extend, as you can see in the staple contour, which is the white contour, it would extend across to the other, to the contralateral hemisphere. And then lastly, the interthalamic adhesion, which we know is present in about 80% of human brains. Although this is functional in animals, really the functional significance in humans is somewhat controversial. So, you know, in terms of how we stated, we've said that consideration really should be given if the tumor involves the medial aspect of the thalamus. So just to conclude for this work, the addition of CT to the MRI-only workflow really did not provide any additional anatomical information in the contouring gliomas, with the exception of cochlea, as I mentioned. And if it's required or it's deemed appropriate by the treating physician, then dedicated MR-T2-weighted sequences should be obtained. We did find that targeted education or workshops did improve physician agreement, at least in challenging OAR such as the cochlea. And what we observed was a very high level of agreement in both target and OAR contours. And with that, we proposed the delineation sort of principles in terms of pathways of spread. And hopefully this can serve as a basis for collaborative trial and study protocols. Because in order to compare results, whether we're talking about dosimetric or clinical outcomes across studies, we have to be talking about the same contours. And multiple studies in the past decade or two have shown repeatedly that there is significant inter-observer variability when we when we're talking about contouring, whether it's for intracranial neoplasms or extracranially. So I think something like this to serve as a baseline for trials is very important when we're comparing outcomes across studies. So just lastly, for acknowledgement, I would like to acknowledge obviously all the physicians that have been involved, radiation oncologists, neurosurgeons, and neuro-oncologists, as well as the multidisciplinary team. And also obviously from the individual institutions that were involved in this particular study.
Eric, thanks so much. Really fantastic job. We'll open it up now to obviously people chatting from the participants as well. But, you know, I guess, number one, what I understand about this is basically you guys have created this consensus recommendations. You've made now a system just for, you know, some of our listeners who are not physicians, and you've made a system by which now you can extend these studies. You can start performing studies about, you know, outcomes where everyone's contouring the gliomas the same exact way. I think it's a fantastic job. It's a great, you know, obviously first step. I find the interthalamic adhesion fascinating and its inclusion. I think it's a great idea. Tell me about these the workshops. And so, is this something that happens in the you know community, in the country, internationally? Are these things that need to be happening in terms of contouring, or do you think that, you know, the way that it's done currently, it's sort of okay?
No, it's certainly not a standard thing that's happening right now, even in academic institutions. I think we sort of just ran it to get everybody on the same page initially. And the idea came up in terms of analyzing pre and post to see if there were actually any differences. And, you know, honestly, to my surprise, even in experienced radiation oncologists who do this sort of on a daily basis, we did see a significant benefit in terms of improved agreement. So I think that's certainly something to think about in terms of disseminating that, particularly, I guess, in community centers.
Yeah.
You know, I'm fascinated by the work that you've done. It's obviously, I think, it sets the bar for future multi-center studies that would use MR-Linac, and even more broadly, just Linac-based treatments for multi-center prospective glioma studies. I think, you know, so much of the literature is clouded by differences in the contours, differences in the structures, that we're not necessarily talking in the same language about the target volumes and the you know, the critical structures that we're trying to avoid. We've seen that in radiosurgery time and time again, and I participated in similar sorts of workshops around you know, how one might contour a pituitarinoma or an artivinous malformation or a meningioma and the critical structures. But I think you've done, you know, really set the stage for what is intuitive and well-grounded recommendations on gliomas research for MR-based treatment trials that will move forward. And I also think that it does sort of point it in the direction of the power of MR-based planning and treatment that I think you know, we're going to see. Not you alluded to a little bit at some of your earlier slides, just the functional imaging. And if we do think that gliomas are tracking along white matter pathways, you know, do we start integrating in even higher levels of imaging analysis, functional imaging and tractography, and looking at you know, some of the white matter DTI changes that may be reflective of invasive glioma extension into those pathways. So you guys have done a marvelous job. I'm happy that you picked JNO to highlight your work, and I think it is going to be a highly cited paper. Yeah,
Jason, actually, I'm glad you brought that up. Eric, have you guys begun looking at the functional imaging, or is this a little too preliminary for now?
Yeah, no, absolutely. Yeah, thanks for your point, Jason. I mean, I think we've actually have done a ton of work in looking at functional imaging. I didn't really show it here. Obviously, it's outside the scope of this work. The sort of the primary sequences that we've looked at are the DWI, our CEST imaging, as well as magnetization transfer, or MT imaging. And there's actually been a number of publications, particularly for CEST and MT imaging, where in the context of gliomas and also actually brain metastases to some extent, where we've shown that you're able to predict responses at a very early time point, usually less than 2 weeks, sometimes as early as a week, in terms of response out to several months. And that's not going to be apparent by looking at just size changes of the tumor, particularly if you just look at the enhancing portion. And I think another aspect to that, another very interesting piece of work that my colleague Sten Marikak here has headed, was looking at prospective imaging using the MR-Linac as patients go through treatment. Because this is really not something that's been done previously. The usual paradigm for radiation planning is to have a set of image for your reference planning prior to getting on treatment, and then that same image or reference plan is used throughout the treatment. And the assumption is that nothing is going to change during that 6-week course of time. Obviously, that's not necessarily true. So with the power of MR imaging, you're actually able to do that on a daily basis. Maybe not contrast enhancement on a daily basis, obviously for reasons of renal toxicity, but we're developing adaptive protocols to potentially do this at least on a weekly basis to alter the radiation plan as the tumor changes, whether that's due to changes in mass effect or edema, or it's actually the tumor shrinking or progressing in some cases.
Yeah, it's fantastic. That's great.
And I mean, that adaptive planning is really an opportunity to revise your target, but it also may be an opportunity to dose escalate to areas that you think are maybe more hypoxic or maybe a bit more, or showing a little bit less in the way of favorable changes, especially as the tumor volume is decreased overall. But impressive work, it really is.
Yeah. So we're just about out of time. I want to thank you again, Eric, for coming along and sharing the work with us. Today's presentation will be uploaded to YouTube actively. It'll probably be live by the time we're done with this. We'll edit it a little bit, but by tomorrow it should be ready to go. We'll share a link. And Eric, is there anyone else? Is there anything you wanted to say? Final words or anything?
No, I think those are great points. I think the future of this, and hopefully this will serve as a basis of that, is really adaptive radiation, potentially shrinking the margins, which is one thing that we've been looking at actively. There's some recent work out of Stanford looking at a 5mm margin as opposed to the usual 1.5 to 2 centimeter, using a hypofractionated approach with just 5 fractions of treatment. And obviously this is early phase study, but it's looked quite promising in terms of, at least from a marginal failure perspective, there's no real difference between what we've seen historically, which is really 80 to 90% central failure in field. So margin may not be as important, but if we are considering shrinking the margin, then that's where MR adaptation comes in, because you don't want to miss the tumor, and potentially a weekly adaptive protocol can fit right into that.
Eric, I think you've put the bar high for future investigations with MR-Linac based treatment for glioma and high-grade GB or high-grade glioma. So fantastic work, and I appreciate you sharing the work. My best to you and your colleagues up there in Toronto. Thanks for providing the outstanding study for JNO and for the audience here today.
Great.
Thank you.
All right.
Yeah.
Take care, everyone. See you next week.
Thank you. Bye-bye.
Bye-bye.
Bye-bye.